Today, you've joined the Parenting Traumatized Infants and Toddlers Myths versus Facts for 0 to 5. Something to note, as I've mentioned, is we have a presenter with us today, Dr. Michael Gomez, who's a returned speaker. We always receive such great feedback when he's involved in our trainings, and I think you're in for a very dynamic and captivating conversation. Really, I can't wait for your feedback afterwards. And I'll tell you just a little bit. There's a lot to say, but we will keep it brief. If you advance me to the next screen, I actually wrote a little something about it. So Dr. Michael Gomez is the clinical instructor at Bradley Hospital Lifespan Institute, a teaching hospital for the Warren Alpert Medical School at Brown University. He was previously director of the Adversity and Resilience Community Center, a child trauma behavior health clinic in Texas. As you know, because we talked about Texas tacos, remember. Dr. Gomez specializes in trauma-focused CBT, treatment of adolescents with problematic sexual behaviors, and assessments of autism spectrum disorders, along with some others like PCIT and Target. He is nationally certified TF-CBT trainer and a nationally certified CE CERT trainer, a model for addressing burnout and vicarious trauma in providers. He's a co-chair for the National Child Traumatic Stress Network's Trauma and Intellectual and Developmental Disabilities Work Group. So with that, we want to say hello and welcome back. We're so excited for this training with you today, Dr. Gomez, and take it away.
Thank you, Jess. I appreciate it. That's very nice of you. I'll have you introduce me no matter where I go. Thank you. All right. So if it gives you Zoom whiplash, folks, I apologize. I'm going to be coming on and off screen, but you do have access to these slides. So don't feel like you have to write everything down. Yeah, this is me. I do that. And so I do a lot of things currently. I'm going to go off screen so you can see my face. I'm currently at Warren Alpert School of Medicine, Brown University. Sorry, I am Brown. It is a university, but it's the actual place in Rhode Island. Okay. And before that, I was in Texas, where I grew up at. I was born and raised in West Texas. For those of you who have heard this before, I've already done this, but for those of you who are new and haven't done this, if you've never been to West Texas, I want you to imagine what you think West Texas looks like just for me saying the words West Texas. Got it? That is precisely what it looks like. That is exactly what it looks like. Like horses, yeah, guns, all the guns. Like racism, yeah, it's locally sourced there. Yeah, that's where it comes from. And so went to school for my undergrad was in psychology and philosophy. So if the whole doctor thing didn't work out, I could think deep thoughts about being unemployed. Got my doctorate from Kansas and did most of my work in trauma at University of Oklahoma. So I bounced around a lot in the US. Love working with Caltra. They've been so lovely and wonderful. And the fact that they asked me back means that that was awesome. I was just expecting not to suck. And apparently I hit that bar pretty well. So I'm very proud of myself. So our topic for today is going to be the 0 to 5 age range. Our little itty bitties. A big part of why I like talking about our itty bitties is one of my mentors, one of the co-developers for we'll talk about in a second, trauma-focused CBT, Judith Cohen, one of the developers, says, bigger kids, bigger problems. So wouldn't it be great if we could catch every traumatized kid at 3 instead of 23, right? Not that we can't help them, it's just that the problem's getting more exacerbated over time. So if anyone has an interest in this age range, I love talking to them. So I appreciate everybody being on this call right now. So here are the things we're going to do first. Also, look at the Kawakas. We're about to talk about like abused 2-year-olds. Okay, we're going to talk about some horrible things tonight. But look at little Kawakas. Aren't they adorable? Don't they look like they exist on a diet of peanut butter and hugs? Don't they? Aren't they so cute? They're little adorable people, aren't they? Okay, so 3 things we're going to do. We're going to learn the impacts, behavioral, emotional, cognitive for this age. Also, we're going to learn what it means to be trauma informed. So I hear that word a lot, and it's kind of a pet peeve that people don't define it because it gets really nebulous. And then I'm actually going to give you some stuff like once we're done with this, you can use it like the next hour kind of stuff. Okay. But again, we're looking at the little Kawaka people. There's a little, okay, again, peanut butter and hugs is what they exist off of. So cute. Okay. Now, when we talk about kids, one of the biggest things I see, not from like people who are social workers or case managers or things like that, I'm talking about doctors, is that they don't understand development and so they make a mistake. So I'm going to give you a very easy heuristic. This is the website. This is a good nuts and bolts way, like ages and stages, but we're going to go through these 3 heuristics. Okay. when in doubt, if you don't know where a kid is at, go down one level. Okay. So most of what we're talking about today is in this level. This is our zero. This is definitely 0 to 5. I define this as called egocentric. It's defined as A plus B equals me. That's how we define it. Okay. That's most like 2, 3, 4, 5-year-olds and many 40-year-old men. But that's not the point of this talk. Okay. And so this is like you have a little kid. This is also like your early elementary kids. Okay. A very key take-home point is anything that happens to someone in this developmental stage, they caused it, not just trauma or anything stressful. So the example I use is I had a colleague when I was living in Oklahoma. There was a very bad hailstorm. So he got his wife and his son, his 4-year-old son, in the kitchen where there wasn't any, like there weren't windows there, like a lot of windows. The kid runs to the but where like you go from the kitchen to the living room where all the glass is because the hail's coming through there. My friend's about to freak out because the son's about to like just get cut on glass, but the kid stops at the doorway and then he says this, "Stop it, God." Because he prays to God every night, like they say their prayers every night. And so he thinks I can call the big guy. The big guy, stop, cut it out, man. You ain't being cool, man. I talk to you every night. And so you cannot argue anybody in egocentric, you can't argue them out of this because their frontal lobe, their analytic skills just aren't developed enough. So what you do is you're just comforting and present. You just got to soothe this person. This is basic. Those of you who know attachment theory, I'm a huge fan of attachment theory. This is basically it. When we get to PCIT in a couple of minutes, we'll talk about what we call pride skills. Those are concrete ways that we can teach parents and kids and other providers. But this is kind of the one you're going to live and breathe on. Now you're kind of more advanced, like 4 or 5-year-olds might go in this one, concrete. This is A plus B equals C. Okay. Now, just to kind of go off screen for a second, here's an easy way to understand concrete developmental phase. Ready? I want everyone to look around their physical environment. Just look around it really quickly, okay? Just do it real quick. Got it? Okay. If you cannot visually see it, it is not a causal factor in your universe. So this is why, especially if anyone who works like daycare or pre-K, like our, kind of like 2, 3, 4, 5-year-olds, they'll come up and they may say something like, Miss Karina, Haley was making fun of me. And Karina's really confused, but she sees Haley and Jess giggling. Well, what Karina doesn't know is that little Michael grew up in a domestically violent household. And so when he leaves that household, causality is gone. He doesn't associate causality with his house. He is now in his pre-K classroom, and Jess told Haley a joke. He sees them laughing. He's still hyper aroused. His body is still remembering all the violence going on at home. So he just associates the first thing he sees. Okay. And so if you have that happen, you have to be very concrete and very repetitive. Repetition is a big, 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 big thing here. Okay. It's okay, sweetie. They're not making fun of you. They're Miss Korean, they're laughing at me. Jess and Haley just told a joke, but they're laughing at me. It's okay. Jess and Haley just told a joke. That's it. So like, for example, when we teach private parts, we say the anatomically correct terms. We're very concrete because if we don't, then we get instances like we had a kid come into our clinic in Oklahoma that said, "Daddy waters my flower," little 4-year-old girl. And the teacher was like, "Oh, that's so sweet, honey." Now, hopefully, if the kid had said, "Daddy put his penis in my vagina," the teacher would have had a different reaction. But that's essentially what she was saying. So we want to be very concrete. And so, good question, Rosalia, you might get 4 or 5-year-olds who are concrete. It tends to happen more in your kind of late elementary phase, like, 3rd, 4th, 5th, 6th grade, and some of your tweens. They may still be in concrete. A good rule of thumb, if you're going past 10 words with someone in this domain, you lost them. So like I'll use private parts as again, because we work a lot with young kids, kind of helping them with like that kind of education. So what are private parts? Parts, bathing, suits, cover. 4 words. Okay. A lot of stuff, for example, American Academy of Pediatrics, things like those resources will have the language for you. There's some like, I think like, Incredible You, My Incredible Body. There's stuff you can get on Amazon. Short, sweet, to the point. You don't have to create it out of whole cloth. Okay? Now, the one that I see a lot of professionals treat the age group we're talking about is this one. They try to teach them A plus B equals Y, abstract. These are your teens and young adults. And they usually are taught, you've probably seen this, like a physician or a psychologist talking to like a 5-year-old like they're a 15-year-old. Now, if someone is in this phase, and you probably won't run into in this age group, they still are not great at this. Like, you still, like, we spend most of our life trying to learn how to drive our own brain. And so people and these are usually teenagers, think of like junior high and especially high school. We got to be patient. Like their brain is still cooking. So still repeat things, but you have a few more options now. Okay? So again, in order, egocentric, A plus B equals me. That's the age range we're talking about. And some of your early elementary, late elementary to tween, A plus B equals C, concrete, and then junior high and for sure high school, A plus B equals Y, abstract. Okay? And we spend most of the rest of our kind of life trying to figure out this stage. It's like trying to master this. Now, common myths I hear for this age range. Well, they can't do treatment. They can only do behavior therapy. They can only do play therapy. You got to be super specialized. You got to be the most trained person in the world to work with these people. And they don't have a high enough IQ where they can do any evidence-based treatment or anything like CBT because they don't have thoughts. And I want to pause on that last one in particular because I just like that just kind of like weirds me out when people say that you don't have that kids who are little don't have thoughts. Like a 4-year-old doesn't have thoughts. My reply is, have you ever seen a 4-year-old? Like, have you ever met one? Because like kids who are like 2, 3, 4, they are only thoughts, right? So at like next time you see like a 5-year-old, just ask them how the day was. How was your day, sweetie? Well, there was a thing, and Miss Marina had a button, and I don't know why Jeanette likes tacos, but I like fish tacos. It's like, well, you sound like you have schizophrenia, man. And so that they're just not organized in an abstract level way. And so, which is usually how the person talking to them is an adult and usually is trying to figure that out. Like, no, they're not going to organize it that way. You're going to organize it in a very nonlinear, self-focused way. Okay. By the way, every kid in this age range is bipolar and is a psychopath. It's totally fine. They usually grow out of it. Okay. But they're totally cool. But yeah, so if those of you who have young kids, you may like, oh my God, is my kid going to be a sociopath? Because he like hit his sister and then was happy and smiled about it. Like, no, he's totally fine. It's going to be fine. But yeah, that's what they do. They're like 5. They're going to be sociopaths, but they grow out of it. They'll be okay. Okay. So don't worry about it too much. Okay. Like most of them do. So, now, as we're talking about trauma, I want to show you a slide, but please don't write this down. I'm just showing this to prove a point. This is what PTSD looks like diagnostically. Again, please don't write this down. But I want to kind of draw a couple of, yeah, thanks, Marina. Yeah, your kid's going to be fine. Probably your kid's going to be fine, Marina. I want to draw some kind of points about, especially for this age range. You will get some of this. You may see this with kids who are traumatized. You'll see, so I'm going to kind of start backwards at E cluster, arousal and reactivity. So in the chat box, here's what that cluster, E cluster called hyperarousal looks like. It looks like this. And in the chat box, does anyone have a guess of what diagnosis this kid might get if they're doing this? Alexandra nailed it. Yeah, ADHD, right? And so again, every 5-year-old has ADHD, all of them. Again, they usually grow out of it. But we need to actually assess for that, right? It's like ADHD is something we actually have to assess for, but often it's not. And I've seen kids get ADHD meds as young as 2 or 3. The worst thing I ever saw was a 3-year-old in the state of Missouri on lithium. That was a licensure violation. We call the guy lost his license, but I know like Brenda is like, oh my God, is he okay? Brenda, he is fine. Do not worry, Brenda. He got re-licensed in Ohio under, same name, but just he got his license in Ohio, even though he lost in Missouri. So Brenda's like, oh my God, is his family okay? Brenda, they're fine. Do not worry about them. Okay. I know you're worried, but he's fine. Okay. Yeah. He lost license in Missouri, but apparently got it back in Ohio. Yeah, that was my reaction to it, Deidre. And so, yeah, but I've seen kids so I'm bringing that up for specifically because no, we got to assess for trauma and screen for trauma. Okay. Now, the other clusters that you're seeing, intrusive symptoms, nightmares, it doesn't have to be about the trauma. One of the saddest things I ever heard a little 4-year-old girl say to me is, monsters visit me in my dreams every night. Saddest little thing. traumatic play, here's what traumatic play is not. Traumatic play is not, Billy has a frog in the sandbox, which represents the womb, and the frog is the father. No, he saw the Muppet movie. He likes Kermit. That's all it means. Some of you, especially people who work with like autism, you've actually seen the symptom, like not this identically, but it looks like autism. So that's what it looks like. Um, and so, yeah, in California, that's true, Marina. Apparently not in Missouri, because we checked that too. We found California, Texas, New York, Massachusetts, and I think Oregon that blacklists you, but apparently not Missouri, at least not in the time. Yeah, we checked that too. We were like, man, we got to get this guy. One day we will. When I'm going to show up at his office, don't worry. I still remember this dude. But I've had a kid who he was 10, a lot of domestic violence. We had a playroom in our clinic in Kansas, and if I let him for a straight hour, he would do this. He'd walk into the room, boy doll, girl doll, under the bed, daddy doll, mommy doll, with this look on his face. We call that dissociation. And so it looks autistic, right? It's not, it's trauma. And that's why I do a lot of work with kids with autism, because a lot of times they get misdiagnosed, or opposite way, like you could have autism, they think it's trauma, the kid has trauma, they think it's autism, right? Those of you who do work with that, like with that condition, or like that's your interest. And so, oh my God, I totally agree with you, Marina. Yeah, that's like, we need to follow Kelly in so many things. So like, just do what they do. But I've had one of the tells, if those of you who do work with kids with like IDD, like I do, is it stress responsive? Like, not does it get worse with stress, but does it turn on and off? Because for this kid, it turned on and off. Autism doesn't work that way. And I've had many child welfare workers and teachers and even psychologists say, well, they have autism at school, but not at home, or vice versa. And I have to explain to them, autism isn't like my uncle's left shoulder. It's like, you know, when it's rainy outside, Michael, my left shoulder's a little autism. There's little flares right up, right here in this rotator cuff. There's a little autism. Like, no, it's not like that. It's pervasive. It's everywhere. And so that kid, like, if we got him calm enough, then he was okay. And so that was kind of our tell. But this kid saw a lot of DV. And so he looked autistic, and they thought he did. It's like, no, this is trauma. So that's what we mean by traumatic play. It's actually the most easy symptom to see. Now, other ones, these I like overt avoidance. It's like, so Billy, tell me about what happened with your dad. Nothing happened. Shut up. Don't ask. Well, Billy looks fine. I mean, let's get to that ADHD right now. I call it a Hamlet. The lady doth protest too much, right? One you see, not usually, sometimes you see it with your little kids, you see it with much older kids. This is if trauma's not addressed. I call it covert avoidance, which usually goes with this D cluster. So the worst case of trauma, yes, the slides will be shared, Stacy. So I think the link was a little bit earlier. Haley might put it in. Oh, Haley's way ahead of me. Worst case of trauma, like the first case of trauma I saw, I was, does anyone know what AmeriCorps is? If you do, put it in the chat box. Oh, AmeriCorps worker. I was an AmeriCorps worker. And essentially, I was, those of you who are AmeriCorps workers know that it's a local Peace Corps. So like they work recession in Detroit, they work NOLA after Katrina hit, gang prevention in Boston, Massachusetts. The place defines them. And so when West Texas had the grant, it was defined as indentured servitude to like to the CMHC there. And so essentially what we did was, I had a kid who had, if anyone knows the ACEs study, he had 9 out of 10 ACEs. So basically had all the traumas. And his worst trauma, he tells me at some point, is he's 8. He's 16 when I meet him. He's 8 when the event he's describing. Single bed pickup truck, dad here, mom here, kid here. They're going around the highway. We called it the loop in Lubbock. They're going around the highway at 80 miles an hour. His dad's on a lot of cocaine. He opens the door. Dad tries to push mom out. Again, the kid's here, mom's here. The kid sees a black river, which is the asphalt at 80 miles an hour at night. He doesn't remember how he got home. He just remembers getting home, because your hippocampus, where your memory forms, is not online when you're about to die. It's really respiration. It's really heart rate, fight or flight, adrenaline. You're covered in neurochemicals. And so dad pins mom to the truck. Kid is 8 years old. Dad is 250 on coke, and he can't do anything. So he runs in, tells his brother and the brother's friends who are there, dad is killing mom. They run out. dad's gone, and I have the same look on my face that you probably have on yours, right? I had that at the time. I was like, man, I don't know what to say to this man. I have no idea. And here's what the kid tells me. The 16-year-old kid says, ain't nothing to say, man. I was slow. I was weak. I was stupid. It never happened again. What do you say to that, right? I had nothing. Because he's right, isn't he? There's a point in which that guy's right. And it took me a while to figure out the error in his thinking. You probably figured it out already. It took me years. First, second, third degree burn. Does anyone know what's the worst type of burn, all things being equal? Between first, second, and third degree burn? Any guesses? Maybe. I'm a professor. I'll wait you out. Thank you, Caitlin. Yeah. Third, does anyone know what burn hurts the most? First, second, or third? Which one hurt? Vanessa's right. First. That's weird? Why does first hurt more than third? Does anyone know why? There's a reason. Vanessa gets it. That gets the answer. When you have a third degree burn, you've cauterized the nerve endings of your body. The first is superficial, so you feel it. Your brain does the same thing when it's under too much psychological pain. It basically, your body shuts down if you're in too much pain, right? Your brain does the same thing. So this kid had third degree psychological burns. We call that complex PTSD or complex trauma. Now, all of this you probably understand all this. One question you may have is like, well, how does this look like in a 2-year-old? And this is where this other diagnosis comes in. So this is where we kind of see some of the problems with PTSD with our 0 to 5. So in response, at the National Child Traumatic Stress Network and at the University of Connecticut's Complex and Developmental Trauma Center, they developed this diagnosis called Developmental Trauma Disorder to actually be specific for the 0 to 5 age range. These are kids with chronic neglect. These are kids with emotional abuse, not just focal abuse. So one way to think of it is this diagnosis is sins of commission, think sexual abuse. This is sins of omission, think neglect. Or like, mom literally never said she loved me. She was drunk all the time. I have a drunk caregiver. Like I work a lot with kids who have parents who use drugs and alcohol. And you'll notice there's some similarity, right? Like the dissociation, you notice some anger and aggression, some emotional dysregulation, but you also notice some different things like problematic sexual behaviors, no empathy. They can't direct a goal, and they wouldn't know an appropriate relationship if it bit them, right? And this doesn't stop at 5 years old. So I have teenagers who have developmental trauma because they grew up with a lot of neglect and a lot of parental drug use. And they do what I do when they have a romantic relationship is they take that red flag down, paint it green, and hoist it right back up. Yeah. And it's like one of my teenagers right now, I know he's going to be a good dad because he already has 2 kids. Ooh, child. Ooh, child. Right? It's like, oh my God, really? But that's because when you have trauma, it's a toxin. Trauma is a toxin exposure. So the key word in post-traumatic stress disorder is trauma. What happened to you? The key word in developmental trauma disorder is developmental. How did it affect your development? Right? Which those are the key things to ask is what happened to you and how did it affect your development? Another way we can ask this is these 2 questions. And this is the whole point. I'll lean up to. When I hear trauma-informed, I kind of cringe a little bit because not everybody, but a lot of people who use it like a catchphrase. Are you in trauma-informed? You trauma-informed right now? You get trauma-informed? Everybody trauma-informed? But no one defines it. So here's the definition. Trauma-informed care means you never ask one question and you ask these other questions. Here's the one question I never want you to ask again if you're trauma-informed. What is wrong with you? Oh my God. Monique, what is wrong with you, young lady? Deidre, what is... No. Here's the question the 2 questions you ask. Ready? What happened to you? Leslie, what happened to you, kid? What's going on? And question 2, what were you supposed to get developmentally, but you didn't? Most kids are supposed to get a, parent who doesn't use meth. It didn't roll out that way for you. And Mark, I appreciate that point. It places kind of blame on the client, doesn't it? There's a lot of victim blaming in the trauma world. That's hard when you're 25. Imagine if you're 5, right? What is wrong with you, Mark? Which implies that something Mark is doing, Mark has complete agency to fix it. Mark's 5. 15, I'll take 15. Do you know any 15-year-old who can actually fix their life problems? I don't. And I work with some pretty high functioning kids. Yeah, it's also victim blaming. That's the reason we don't want you to ask that question anymore. And instead, we want to ask, has anyone read Oprah Winfrey's book, What Happened to You? It was written in conjunction with Bruce Perry. I don't know if anyone's read that. If you get it on Amazon. So 2 points to that. First, Oprah Winfrey is a national treasure, and I will fight anyone who says otherwise. She is a national treasure, that woman. Second, is it's actually a really good book because I look for books like that and my understanding, Jody, correct me if I'm wrong, is it's like a conversation between her and Dr. Perry. And I love it because Oprah's asking questions that like the lay public would ask, like, so what does this mean or what is it? And I love that style of writing, that dialogue style, because I think it's more accessible to people who don't know anything about this, and that's why I do talks like this, is because we need to get this out there in the public. And so, yeah, Dr. Perry's brilliant. And so I thought it was a very accessible book about some very intense topics, but it's titled What Happened to You? And that's the reason it's titled that. And that's why I'm a big fan of that, is because it's one of the two questions we want you to ask if you're trauma informed. The other thing you saw on there was rememberingtrauma.org. It was developed by Northwestern in conjunction with the National Child Traumatic Stress Network, part of the organization I'm involved with. It's for transition age adult. It's focused on that, but there's a good thing about it. It's one of our resources that focus very specifically on racial, cultural, and historical trauma, and that's a huge thing that we want to emphasize in the experience of trauma. Is that, yeah, you live in a systemically racist country, and that's going to factor into your trauma response. And it's basically a short film. The first one is about a transition age youth named Manny, and it's a movie. It's a short film. The second film they have is basically director's commentary, and I think it's Dr. Cassie Cassell at Northwestern, the person who developed it, has a very good phrase which applies, especially very important for this age range. She says, traumatic stress is the great imitator. And here's what she means by that. Traumatic stress is designed to look like everything but traumatic stress. It's designed to look like ADHD. It's designed to look like anxiety. It's designed to look like depression. It's designed to look like an eating disorder. It's designed to look like autism, headaches, stomach aches, joint pain, right? Learning disabilities. Now, it's not saying they don't have those, but it cloaks itself in a condition. And when a provider, like a therapist or a teacher, comes in, they do what I did for many years, and they play what I call therapeutic whack-a-mole with the kid. Let's treat the ODD. Great, now they're depressed. Let's treat the depression. Now they're anxious. Let's treat the anxiety. And they keep whomping the mole, but they're basically like they're mowing the weeds. They're not pulling the roots. Okay? So when I work with people who do psych evals, because I do a lot of psychological evaluations, I say my actual evaluations haven't really changed that much. The only thing I do different is instead of asking about trauma last, I ask about it first. What happened to you? What is something scary, dangerous, confusing that's happened to you? I ask the caregiver, what's happened to your family? It could be something like, yeah, like the families I work with, every female has been sexually assaulted going back to the 1800s. Could be, yeah, we were in Florida. We were caught in the hurricane. Could be anything. And so that's really the main thing I do different. But that term traumatic stress is a great imitator I use a lot. So I know that I look 20, I'm not, but I look that way because evil doesn't age. So often when I work with schools is I'll have a teacher, and you'll look much older than me, and I'll get this like, Dr. Gomez, I've been an educator for 25 years. I think I know a thing or two about children, Dr. Gomez. Right. And I know what I want to say to that teacher, but what I don't say, don't say it. So what I tell that teacher is, well, traumatic stress is the great imitator. It's designed to get by a 25-year educator. Because if you can actually shine light on it, it withers and dies pretty quickly. So I was at a conference I think in Philly, and I ran into a colleague I'd known a while back in KU Med, and he's a pediatric HIV researcher. So he works in pediatric HIV populations, and totally different conferences. We just ran into each other. So later that night, we're having dinner, and I used that term, traumatic stress is a great imitator. And he says, that's a lot like HIV. And I'm like, I'm not super familiar with that literature, man. He said, oh, HIV is photosensitive. I'm like, no, still don't know what that means. Like, oh, you put the human immunodeficiency virus on a petri dish and expose it to light and air, it dies relatively quickly. That's why spit doesn't transfer it, sweat doesn't transfer it, tears don't. It's not that communicable in that sense. But if it's in you, it's, it's problematic. And I said, that's kind of not a one-to-one parallel, but that's actually kind of a good parallel with trauma, is that if we can expose it to light and air, it dies pretty quickly. So all the things I'm about to talk about, like the tools we use, the kind of treatments that we use, things on secondary trauma, all of those, please, use those as you need, but really by just asking the question, what happened to you? Instead of asking, what is wrong with you? Oh my God, what is your freaking problem? You are doing such a healthy thing for someone. And by the way, if you can zone out the rest of my presentation, Jess and Haley will be very angry. I'll be fine. So keep going on Facebook or Instagram and watch that TikTok video. That's cool with me. But just remember these two things. Ready? This is all I need you to remember. Ready? 2 rules for trauma across the age span, across the lifespan is this. Rule 1, trauma disconnects, healing reconnects. Say it again. Trauma disconnects, healing reconnects. I don't just mean your emotions, I mean your neurology starts disconnecting in reverse evolutionary order. People with focal trauma, like they've had a trauma event, often their frontal lobe can still work. It's a little jarred, but it's okay. People with sexual assault, very severe trauma, they didn't have it as a child, but maybe as an adult, their frontal lobe goes offline and their limbic system is really bright. That's why they may get very angry. They may have a panic attack. They may hyperventilate because their limbic system, where all their intense emotions are, just goes to 11. If you have chronic, repetitive, and especially early childhood trauma, this goes offline, this goes on the fritz, and all you're left is with this. So those of you who work with, like, let's say high schoolers or junior high kids, if you've ever seen a kid black out and he's like, I really don't remember. Like, dude, you hulked out and hit 5 teachers. Well, it's like, dude, I don't remember, Miss Agana, I really don't. I'm sorry. And sometimes they're lying, but usually you can tell that they're not. That's because this went offline and this went offline. And so we have to reconnect it. And it's not as intense as it sounds. So like, I'm a former smoker. I apologize for the smokers on the Zoom. I'm a smoker. I apologize if I offend you. I still miss it. God, do I miss it. And so when I stopped smoking, like in my early 20s, the first year or two I was not smoking, oh my God, I was hacking up stuff. It was good. My lungs were junk. Now in my 40s, my lungs look like a non-smoker because I haven't smoked in over a decade and a half. And so your brain is less like this bottle of water and more like your respiratory system. It's much more pliable than we give it credit for. So the reason I do talks like this is if you catch them at this age range, it's like silly putty. It's like wet concrete. It's like so malleable. Our treatments are so fast, as you'll see, like they're really effective really quickly. So like I have a 6-year-old right now with sexual trauma. Their treatment protocol lasted a total of 20 weeks max from the time they walk in to the time they graduated, max. We probably could have done it in 15. I have a 20-year-old right now. They are in about month 10 of their treatment, and they're just about to start talking about their trauma, which is actually pretty fast for them. Like they were very like, I'm not talking about this crap. They're doing a really good job. They're what we call stably unstable. Or as I refer to myself, I'm a Denver omelet. I just know where all the stuff is. Okay. And that's good for them because they're not using, they're not cutting, they haven't tried to kill themselves. It's great. Role 1, trauma disconnects, healing reconnects. Role 2, ready? Being heard, being recognized is the opposite of being traumatized. Being heard, being recognized is the opposite of being traumatized. Think about a lot of the kids we see who have trauma. They were alone. No one was there. No one could protect them. No one would protect them. So just by asking those questions like, what happened, man? They're like, what were you supposed to get? But you didn't. You're recognizing them, right? Trauma is dehumanizing in every sense of the word. Like a lot of you sometimes hear a lot of, especially adults in late adolescence say, I'm not even human. That was my 16-year-old kid in Texas. It's like, I'm not even human, I'm a monster. Like they, and really believing that they're not a human entity. We're going to recognize your humanity. We're going to recognize your personhood. And however you can do that, you're doing something that's very trauma-informed, very healthy, and very powerful. So let's go to the nuts and bolts, okay? If you can ask one question to see if a treatment is evidence-based for trauma in a kid or family you're working with, right? Then, yeah, Marina, it broke my heart too. It really broke my heart. I was like, oh, this poor kid. Then I want you to ask this one question, ready? Hey, caregiver, what's the therapist doing with you? And if there's crickets, then that's not an evidence-based treatment for trauma or probably for anything in kids. So here's why that is. there were two, I'm going to cite two studies very quickly. There is a very smart guy at Harvard named John Weiss who asked very simple questions that are ridiculously hard to answer. And one question he asked is, what makes child therapy work? Super simple, right? Super hard to answer. And this dude looked at everything. He looked, is it master's or PhD? Is it inpatient or outpatient? Is it school-based or office-based? Is it everything? And he found that the most powerful single predictor for if a kid gets better in therapy for ADHD, depression, generalized anxiety, PTSD, autism spectrum disorder, OCD, bipolar, borderline personality disorder, medication compliance, pediatric obesity, and a bunch of other things is caregiver. That's it. Not a therapist, but a caregiver. Teachers technically count in that category. Daycare workers can count. CASAs can count. So basically, is there someone besides the therapist or doctor who gives a crap about this kid? And if there is, and they're participating in helping support the healing, that's really powerful. That's literally the most powerful thing we got. By the way, probably need a PhD to tell you that, right? 168 hours in the week, I would see the kid one. It's arrogant and disrespectful think I can fix that kid in an hour, right? That's a super arrogant thing I just said, right? More intelligence, I dump my wisdom into the caregiver's head and they don't need me anymore. So teach the fish. Now I'll give you some fish because I know you haven't eaten, but really we're teaching fishing. Okay? So that's really the only question that if you ask one question, if you want to tell something's evidence-based or not, especially for trauma, foster mom, what's the therapist doing? I'll just drop them off. That's probably, I'm not saying it's not unethical, it's not illegal, it's not necessarily harmful. It's probably not helping their traumatic stress, their developmental trauma, their depression, their anxiety. It's probably not helping any of that. And so the treatments that we're going to talk about are going to do all those things. Okay, I'm going to give you three. These are not the only three, but it gives you a good idea of kind of what to look for. And that's right, Mark. So an adult who is a stable, safe, non-offending entity. I do work with offending caregivers, and you'll get an example in PCIT, but we got to do some extra steps for an offending caregiver. Okay, but yeah, it can be fought. So I think out of my caseload right now of 25 kids, I only have 5 bio parents. Everyone else is a grandparent, which is the largest demographic of foster parents, grandparents raising grandkids. I have teachers. I have a bunch of foster parents. I have an inpatient floor staff, and I have a court-appointed special advocate and a police officer. And and a coach. Sorry, I forgot the coach. Yeah. So most of them aren't bio parents. And so it's great if they are, but it doesn't have to be. So one thing I usually tell people is that caregivers are the solution, not the problem. Yeah. And I usually talk about 3 types of problems when I talk with caregivers. I say, mom, especially if they're having a lot of problems with the kid. I'll say there are 3 types of problems I usually see. One is strep throat. Give your kid a pill, they're going to be fine. Your kid does not have that type of problem. I'm sorry. The next type of problem I see is stage 4 lymphoma. Kid's terminal, and the most we can do is make them comfortable, but inevitably they're going to deteriorate. I think mom, dad, sometimes you think your kid has that. They don't have that. They have the 3rd type of problem. They have diabetes. And that's essentially, we manage the problem. We give you skills, you manage it, and you're fine. I will say the reason I really like doing talks in the 0 to 5 age range is that's where I see strep throat. My teenagers and 20-year-olds is where I see diabetes. And I kind of don't believe in stage 4 lymphoma. I'm going to be honest. I don't think there's a kid. Now, I believe in the kid I can't reach. I believe in the kid I'm not skilled enough to work with and help. I just don't believe in the kid that's terminal, psychologically speaking. I just don't believe that. I do, however, believe that some parents totally believe that. And they're at the moment I meet them, there's nothing I can say to convince them otherwise. And so I don't want to invalidate them. I also will just we're going to kind of have to agree to disagree. I'm just not going to stop having faith in your son or daughter. I don't believe in the kid that's beyond help. I believe in the kid that's beyond my help. That kid totally exists. I just don't believe that kid that's not able to be helped. But if you have a kid 0 to 5, they're probably in strep throat area. Okay, we can actually do some stuff. Not, by the way, don't give them a pill. That's rare, in that age. What I'm talking about is a focal intervention that's time limited, that actually will work fairly quickly. You'll see improvement in 4 to 8 weeks. That's when you start seeing them get better. Just like if you took amoxicillin, a couple of days later, you start feeling better, but finish the whole bottle. And so the other part of that is I usually talk with caregivers about what I call wood versus grease fires. And what I mean by that is, especially if you work with seasoned foster parents or teachers and parents usually are very well situated to use wood fire techniques. And here's what I mean by a wood fire technique. Brenda, please sit in the chair. I want to. If you don't sit in the chair, young lady, you're gonna lose a sticker. Fine. Thank you, Brenda, for sitting in the chair. I really appreciate it when you do that. That's the rhythm. that's the rhythm. Okay. Now, that's a wood fire. Here's the grease fire. Brenda, sit in the chair. Brenda, young lady, if you don't sit in the chair, you're going to lose a sticker. Boom, flips over the table, tears through. This is also, Caitlin, why I don't like stickers too much, because that's oh yeah, you just triggered the kid. That's a grease fire. Okay, grease fire, it's a trauma response. Okay, it's a stress response to be more technical. Let's do that again. Brenda, please sit in the chair. Okay, 1 to 10, little, middle, big. Where are you at? Okay, let's go ahead and use some of those color breathing that Miss Haley taught you. You soothe a stress response, you cope with it, you give coping skills, okay, which we're going to look at some in a second. And so the first question I get, especially from teachers, is how do I tell a wood fire from a grease fire? And my reply is, in real life, how do you tell a wood fire from a grease fire? Throw some water on it. What happened? Got worse. Don't do that again. That's the answer. Still use your behavioral. If you really like stickers, me and Caitlin aren't too big of fans of them, but if you really like them, feel free to use the stickers, man. I don't care. If it works, it works. But don't keep throwing stickers at the kid when they're having a trauma response, a stress response. Okay. And this is a lot of this this is what your work is with the families you tend to interact with, is trying to differentiate those. Often you can kind of tell, right? And so you don't need a PhD to tell that, right? You're like, hey, I think after visitation, when he starts getting moody, that might be grease fire. Like, we don't need to come down and say, you got to follow the rules and you're going to lose your stickers. You can say that on a Wednesday, but when he gets back Sunday night, that's probably not the time to do that. And in caregivers' defense, often they may look perceptually the same. Like, he gets mouthy. Okay, he just wants a cookie. Okay, he gets mouthy. He came back from visitation with Biodad. Okay, so they could look the same, so it's really confusing from the parent perspective. Like he's doing the same thing. Well, it's a timing issue. So let's try some different skills. Like, what's that definition of insanity? Doing the same thing over and over, expecting different results, right? So one of the treatments that's really good in this age range. This is actually it. Now I have the age actually that it's a little dated. It actually goes down to 12 months to 11 years. This PCIT. It's about, now for a 12-month-old, this is like an 8-session model. For a kid who's like 2, 3, 4, 5, it's about 15-ish. And it's divided into 2 halves. Child-directed, this is our attachment phase. And parent-directed, which is the discipline part, or parents say, why I came here in the first place. This is also one of the few, quote, behavior therapies. It's not a behavior therapy, but they call it that, that actually has been tested with kids with autism, kids who are not neurotypical. And it's one of the few treatments that works for physically abusive or neglectful caregivers. It gets them not to do it again. And here's how it does that. So it's divided into 2 parts. And same guy I talked about earlier, Dr. John Weiss, did another study. He said, what makes parent programs work? So those of you who work with child welfare like I do, I think I have those families that they should get a punch card, because at least on their 10th investigation, they get a free coffee, right? Because that's all I get. It's like, I did the program, give me a kickback. I'm going to abuse them again. Give me the like, they just keep coming in and out, right? So let's give them at least a free coffee on that 10th investigation. I don't know. That sounds fair. But yeah, that's the people I work with. And so at Oklahoma, where they did the original research on this for parent-child interaction therapy, we said, give us those families. We want those families. And so they had 3 conditions. Control group, there's like business as usual. They had what's called wraparound. I was a wraparound worker a long time ago, back in the day. And so I call it kitchen sink approach. They're going to get substance abuse counseling. They're going to get family therapy, individual therapy. Mom's going to get individual therapy. They get group therapy. They have everything, kitchen sink. That was 2. Here was condition 3. PCIT, clean UAs, housing, and a job. That's it. That's all we need, mom and dad. Here were the results. Condition 1, the control group, no change. Kept coming back in as usual. They did what's called the survival analysis. Like, we're not going to go over stats, but here's what a survival analysis is: statistical Hunger Games. May the odds be ever in your favor. So basically, if you come back in, sorry, you got kicked out. Like, sorry, you got, taken out by District 1. Okay. So you're out of the Hunger Games. Okay. So you come back in if you offend again. Okay. And so group 1, control, no change. Group 2, the wraparound, the kitchen sink approach, no change. They kept coming back in as much as group 1. Group 3, we're going to do PCIT, clean UAs, job, housing. We followed them almost 1,000 days. I think it was like 966 days. They never came back in. Now, we thought like maybe they're better offenders. Nope. They kept tabs on them. Nothing. They're doing good. No new offenses. No neglect or physical abuse. And here was our thought. Okay. So you ever had a 3-day weekend, right? And you get a little too overconfident. You're like, I'm going to clean the garage. I'm going to clean my closet. I'm going to clean the kitchen. Right? And you do none of that, right? Like, I'm going to watch Sandman on Netflix for like on loop for like 3 days. That's what you do. That's what I did my last 3-day weekend, right? Yeah, exactly, Andrea. And so Columbus Day's coming up, like Indigenous Days coming up, that's going to happen, right? Now, some of you, though, may do this. All right, I don't care what the heck I do. That freaking closet's clean. I'm going to clean that by Monday. That's going to be clean. And you start Friday night and Saturday evening, you're done. Like, oh, let me take a shot at the garage. Right? Think about the families who keep coming back in and out of child welfare, overwhelmed. Usually they're traumatized themselves, intergenerational, often low SES ethnic minority, right? These are disenfranchised populations that don't have a lot of power and there's a lot of coercion in their history and in the systems they're in. So we're like, let's give you something manageable to do and see if you do it. Right? So I was involved as one of the people doing PCIT in some of this stuff. And I remember this mom, 20-year-old mom, 5-year-old kid, do the math, right? And this mom was a system kid. Mom had grown up in foster care, lived in there, was abused in foster care. So obviously she did not have, and so obviously when child welfare came, when she neglected her kid, mom was, drinking a lot. Not good. Okay. Charmaine, I can actually send you some of the studies. One of the original PIs on it is Mark Chaffin, Chaffin. Another one, a lovely name, lovely doctor, Dr. Beverly Funderburk. It's so cool. Such a cool name, Funderburk, right? She brings the thunder. But if anyone's interested, I can send those to Caltrin if anyone's interested in it. There's multiple studies at this point now in other universities doing that. And so I have this mom. We're in the first second session, and we're working on something called labeled praise, trying to get her to praise her kid. And the way we do it is, it's actually easier. During COVID, it was actually easier because we usually have like a Law and Order mirror, right? So I'm behind the glass. I have a mic. Mom has a bug in the air. During COVID, we just did it this way. We have mom have like a little, like her phone. We have a camera. That's it. Like we just do it through Zoom. It's actually much easier now. And so mom puts in a Bluetooth. We're good to go. Put in your Apple Pods, whatever. And so I can see mom's getting frustrated. She's not able to do the praising. So I pause the session. My co-therapist goes in to watch the kid. I pull mom back into the obs deck. I say, hey, mom, what's going on? She's like, can't freaking do it. What do you mean? Can't freaking do it. And I'm like, why do you think this is hard for you? Like, I believe you, but why do you think it's hard? She's like, I never got it as a kid. Okay, I'm going to pause. I believe you, mom. I 100% believe you. But I just want to make sure I heard you correctly. You are saying, and I 100% believe you, that in 18 years of childhood, no adult ever praised you. Yeah. Like, that may be one of the saddest things I ever heard, mom. Would you like to give that gift to your son? She's like, that's why I'm here. I can work with that. Like, I can work with that. And she did amazing. She did great. We just had to kind of break it down a little more for her, but she did amazing. And she had come into child welfare purview 5 times. We didn't see her 6. And so it's, also it's like the way we got this done in a crimson state like Oklahoma, we said we're just cheaper than incarceration. And we're not burning through your workers. They don't have to deal with these families. These are usually the families that burn the workers out. So give them to us. And so, because I also was a court-appointed special advocate. As an aside, CASA, those of you who know CASA, those of you who don't, Court-Appointed Special Advocate is a volunteer organization that works with the courts and kids in child welfare to be their advocate, since their usual advocate, their parent, has been compromised because they're under scrutiny for abuse or neglect. You know how you can talk crap about your families, but I can't? Here we go. Okay, so I was a CASA, and I love CASA, but I also know that it's a wide range, right? You get someone like, I was 20 years DCYF, CPS, and someone, a real person. Habitat wasn't taking people, so I came here like, ooh, it's gonna be tough. And so so there's a wide range, and sometimes, like the training may not, the region I was in is West Texas, wasn't that great. It's better now, but it's a volunteer organization and subject to volunteer. And so if anyone like works with child welfare, and imagine if anyone knows the Pixar movie The Incredibles, and if you think of like police are Mr. Incredible, medical is Mrs. Incredible, and you pick an Incredible to lump onto a system, Casa is Jack Jack. Casa's the baby, literally the most powerful Incredible, but sometimes they don't tell us how to use our powers. Okay. And so when I was at Casa, I would go to court and here's what I would hear. Yana, I was just trying to discipline my boy. That's all I was doing, Yana. And I'm sitting there like, you are a sack of, you broke your 4-year-old's nose. You are a lying sack of, man. That was my thought. But I did Casa long enough where the more disturbing thought came to my head, which is, oh my God, you believe that? You really think punching your 4-year-old in the face is discipline? And so, whereas the legal system in Oklahoma came like, these are pieces of crap, they're worthless people, they're hurting kids, and they wanted to throw the book at them, which just made them like they didn't teach them any skills. We said, hey, maybe just radical idea. Let's just at least try to start with a couple of these families and assume they actually don't know how to freaking parent, because parenting is a skill, right? Those of you who are parents know that it's a skill. And if you've had one kid, you've had one kid. All some of you have like 3 different kids. Like these are all aliens living in my house. I don't know who is living in my house. Like my daughter is so different than my son, or like, right? And so, yeah. And so it's, having kids is hard, right? I don't think you're a real parent unless you thought about abandoning your family, moving to Costa Rica under an assumed name, and opening a margarita shop. If you haven't had that thought at least once a day as a parent, I don't know if you've actually been parenting correctly. And then if you get to Costa Rica, ask for Pablo, tell him Gomez. Okay? Yeah, because sometimes that does go down that way. But yeah, so essentially it's a skill, and we taught it as a skill. And so these are the skills we showed them. These were the bits. So if when you read the research articles, there's a PDI section, which is like, we'll talk about in a second, but it's really like the quote discipline part. That's not the important part. The attachment part is the important part, because we found that the most progress they made was in this part, not in the other part. And we call these do and don't skills. So don't skills, no commands, questions, or negative comments. So Doc, I can never ask my kid a question. Not what I said. For the 1 hour a week you're here in therapy and the 5 minutes of homework we give you every night, don't ask questions. Right. And this is an important thing. So let's say that I'm Andrea's supervisor, and I say, hey, Andrea, how are you doing today? How's the week going? What are you doing this weekend? How are your kids? How's things going at work? Even though I'm a fairly nice guy, if I'm Andrea's boss, that questioning makes Andrea a little nervous, because like, I thought we were cool. Are you going to fire me or doing layoffs today? Yeah, because parents and kids should have a natural power differential. Okay. We don't do commands because those of you who have kids who are very defiant know not to do that, right? Like, because they'll just like, do you want to take out the trash? Nope. Right. That's what, like I did. Yeah. And so, so my blessed saint of a mother had the misfortune to have the 2 types of children in the world. So when my brother would get in trouble when we were young, she would say, Mark Anthony, you're in a great deal of trouble, young man. And my brother would say, I'm sorry, Mom, I'm going to punish myself, because he's a stick kid. He's a vinegar kid. When I would get in trouble as a young child, she would say, Michael Daniel, you're in a great deal of trouble, young man. And I'll say, oh yeah, Mom? See the rich? I did, man. You about to be living, Mom. Like, that was me at 8. And the fact that she didn't murder me makes her a saint. Okay. And I feel like, so I'm a honey kid. I'm not a stick kid. The stick doesn't work, right? Like, it just doesn't work on me. So like, I would essentially like when I got spankings, my mom didn't know what to do. She spanked me. I like, is there a window open? I was such a jerk to her. I feel so bad. I still call her. I'm like, Mom, I'm sorry. She's like, Mijito, what happened? 1998. I was like, August. I remember. Like, I'm so sorry. I feel so guilty, and I feel so bad for my poor blessed saint of a mother. But so we want to have the attachment bond reset, or sometimes rebuilt entirely. And so the way we do that, we try to let's control these, put a lid on the don't skills, but we need to give you something to do. That's what's missing from these parents. And what we do is we call it pride, labeled praise. So could be, so I'll give you an example of unlabeled praise. Ready? Is good job, Mark. What What do you mean? Hey, Mark, good job with that comment about, asking about the caregiver and clarifying for that, because that's a really central point to a lot of therapy. I just explicitly told Mark what Mark did well that I want to see repeated. Also, you've never come home from work and said, you know what? I'm getting too much praise over there. Just too much praise. They're just too positive over there at Caltran. Like, I don't know, Angelina, I think they're just too positive over there. I think you need to, tone it down, Charlie. I mean, just too much positivity. I hate that stuff. No one's ever had that day and no one ever will. Okay. So yeah, we want to reflect statements. We actually have healthy side effects in these treatments. A healthy side effect we found for PCIT is kids with speech problems their speech gets a little better. Like, I have a ball. You have a ball. Yeah, a ball. Yes, you have a ball. Yeah, we're repeating their language. We want you to imitate their play if it's appropriate. If it's not, I feel bad because I had a mom who the mic went off and we didn't know, and the kid just started cussing at mom like, I'm a just started reflecting. I was like, no, don't do that. We want you to describe what they're doing. Like, you're sitting on the chair and you have the red block and and we want you to combine them, and you have the yellow block, and you are such a good builder. And we want you to be enthusiastic. We actually developed the enthusiasm one because we worked a lot with moms with postpartum depression, and we had to work with them on that, which is a valid thing. Okay. And so these are the things, these are it. We want you to master these skills with your kids, with your young kids. And so with kids who are 12 months old, we actually just need you to do this. We don't actually need you to do the discipline part. We just need you to do this part where we're building relationship, building attachment bonding. Now, when I talk about active ignoring, with active ignoring, my favorite example of the opposite of active ignoring is, I'm ignoring you, young lady. Young lady, I am ignoring you. I'm ignoring. It's like, okay, that's not how it works. Right, Deidre, I just got to get out of sight. Like, Deidre, I'm ignoring you. I'm ignoring you, young lady. Yeah, it works. Yeah, and you saw also Monique caught it too. That parent wasn't like, God, I'm so mad. Like, yeah, you can be upset, but we have to have you regulate your own emotions too. That's a big part of it. Now, that's what PCIT looks like. We try to get caregivers that skill. Another one, this is 0 to 5. This is called child parent psychotherapy. I love this because now here's the catch. PCIT is like about 15-ish sessions. CPP is a whole year, but it's kind of meant, if anyone's seen nursing programs where nurses come in the home, teach parents how to hold the baby, how to administer formula, it kind of has that feel. That's why it's so long. But essentially, you're teaching a parent to speak play. It's really good for intergenerational trauma. God, it's so good for intergenerational trauma. So if you have those families who everybody's been abused going back to the 1800s, this is a great, not saying PCIT will be ineffective, but man, this is so good. If you have access to CPP, please use it. I'm going to actually have you see one of the trainers for CPP talk about what it is in a very short clip. So,
Child Parent Psychotherapy, or CPP for short, is a therapy for children birth through age 5 who have experienced really scary, dangerous, or violent things such as child abuse, so physical abuse or sexual abuse, or car accidents, or even experiencing things like being in a fire or a tornado. CPP is evidence-based, meaning that there is a lot of research behind the effectiveness for using this treatment with young children and families. We know that CPP is effective because of the research that we have. So treatment is conducted on a weekly basis, so children and families are seen by a therapist for weekly sessions. As part of the treatment, children and families are seen together, so one child and one caregiver may be present. CPP really aims to build skills within the family and improve the relationship between the caregiver and the child, and also to help the child heal from that scary, dangerous, or violent experience they might have had. CPP is wonderfully powerful and effective when in the hands of a well-skilled therapist to be able to really help these children and families learn.
In CPP with children, it allows us to speak their language, and the language of play. It helps parents to tune in, become attuned to what's going on in the present moment and what's in the room. It helps us to align with children in their point of need. And it also allows children and parents to continue to grow. It kind of restores and heals and allows children to get back to the business of being kids. One child really sticks out in my mind when it comes to CPP. It is a very young girl who had some really severe panic attacks, had difficulty when parents left the room. Through the process of CPP, she was able to use toys to just kind of convey what was going on the inside. And as she played, and the parents played beside with her, they were able to communicate in ways they weren't able to before.
We find it to be tremendously useful and helpful and healing for children to be able to speak what's been unspeakable before, or show through their play what's been unspeakable before, so that they can begin to heal and move through that traumatic experience.
Right. I like that term. They say a couple of terms like speak, play. Love that. It is a commitment. If you can get a family to commit, oh my God, I would recommend that. I do a lot of TFCBT and PCIT. But if I have a choice, I'll usually kind of default to CPP just because it covers this entire age range. And it's usually used for the more complicated trauma cases. And it's also very parent-centric in the sense of we're going to give you skills to learn how to talk to your kid. And also the second phrase is to speak the unspeakable. And so, because play is a language and we communicate through play. In the disaster mental health response work that I've done, I've had a kid, I remember I had a kid say, well, how is speaking play different from traumatic play? And so they was in more Oklahoma tornadoes in 2013, which seems like a long time ago. But when I said, well, were you out this weekend? And it's like, yeah, I was at an outdoor cafe. It's like, were the kids playing? Like, yeah. What were they playing? They were playing tornado games. Now, was it like that kid who's like hitting the, no, here was the game. Get the dog, we gotta get the dog, gotta get in the shelter. Oh, don't forget the social security car. Like, yeah, you're playing the tornado game. There was movement on it. So when you have those kids who are very stuck and, those like super traumatized kids, this one can help them kind of get unstuck too. PCIT can, and the next one we're talking about, TFCBT can. I really like this treatment a lot, but it's not accessible everywhere. But if you do have it accessible, I would totally recommend it. It's also very flexible because they can switch out a lot of they have sometimes like standardized toys. You can switch them out. They do a good job of incorporating different kind of ethnic, cultural differences, also neuro differences. So like kids who are deaf, kids who are blind, they can use it with them too. So where there's a current grant that one of our NCTSN sites is doing to modify for kids who have visual impairment and who are deaf, and super cool stuff. Highly recommend it. Another one that we talk about is TFCBT, trauma-focused CBT. This does go down to 3 cognitively, and it's been done a lot. It's essentially like amoxicillin for traumatic stress. It was originally created for sexually abused preschoolers. That was its original population, and it still works pretty well. It's a lot of data. The one thing I want to highlight on this slide is we expect kids to have lower PTSD, lower shame, lower behavior problems, but also caregivers get lower PTSD, lower depression, lower emotional distress. And so sometimes that's finding confuses people. And the way I explain it is like, let's say that, Amber brought in like 4-year-old kid for therapy. And it's like, all right, Michael, fix him. He needs to be fixed. Like, okay, Amber, do you need any help? No, I'm fine. Okay. And we know that most of the caregivers we work with, regardless of age of the kid, they themselves often need therapy, right? Sorry, they need Jesus, but we will take an LCSW in a pinch, okay? And so the way we backdoor the skills is I'll tell Amber, like, oh my God, Amber, Mark is so aggressive. He's just so angry, right? Amber, like, I know, Dr. G, yeah. And I know, Amber, you don't need to learn how to relax or how to breathe correctly. But Mark, oh my God, he's such an angry kid. So how about you pretend you don't know how to breathe? And we're going to teach Mark something called color breathing. And he's going to come and teach you. You're going to pretend not to know. But just so you know what to look for the homework, for Mark, not for you, for Mark, here's how it looks. So I just backboard the skills, right? Okay. And I've had it happen a lot where at the beginning, a family, this had this more times I can count. I'm fine, doc, I'm fine. Like, all right, man. And as we're integrating them in the treatment, at the end of it, I've had several parents say, hey, doc, remember you said you could get a therapist for my stuff? Like, yeah, man. I think I'm ready to call that person now. All right, ready to go. Because like they just saw their 5-year-old kid talk about their sexual assault, but like, so they're 25 and like, it's kind of hard not to say that. But remember what we talked about in the earlier slides, like those sins of commission, omission, TFCBT is really good for those sins of commission. It was originally created for sexual trauma, for death, but also keep in mind that they have a memory of it. Right. So if they have a memory, great, but a lot of kids in this age range may not, or it may be more complicated like developmental trauma. And we're still working on kind of how to modify the model for those like kids with developmental trauma like neglect. And we're making some strides on it. But if you see a kid like they were physically abused, they were sexually abused, they had a loss and death, and especially if they have any memory of it, then this one is the one I kind of usually lean to. There's also a misconception of what CBT looks like. And what it doesn't look like. If we have any people out there who have like a clinical leaning or clinical background, this is the actual manual. This is what it looks like. You can get this on Amazon, but I want to show you what CBT looks like, what it actually looks like. I think this is a 3-4-year-old kid. Ready? This is what it looks like in a 3 or 4-year-old kid. This is CBT, textbook CBT for a 3-ish-year-old kid. Everybody ready? Here's CBT.
We gotta tell mommy when you need to pee. Tell mommy when you need to poop. Tell mommy when you need to pee. Tell mommy when you need to poop. We need to pee pee. We gotta poop poop. We gotta pee pee. We gotta poop poop. You gotta tell mommy when you need to pee. Tell mommy when you need to poop. Tell mommy when you need to pee. Tell mommy when you need to poop. We gotta pee pee. In the potty. Gotta poop poop. In the potty. We gotta pee pee. In the potty. Gotta poop poop. Tell mommy when you need to pee. Tell mommy when you need to poop. Tell mommy when you need to pee. Tell mommy when you need to poop. And then you get a prize. And then you get a prize. And then you get a prize. And then you get a prize.
Yay, Janaea. Okay, so a few things with that clip. First, that is the cutest freaking kid who ever existed in the world. Okay, and I will have words with anyone who disagrees. Okay, that is the cutest little button in the world. Okay, that's CBT. That's it. Okay, CBT is actually really easy in kids that are young. And so it's actually easier than anybody else. You've done CBT already as a parent. So those of you who are parents, I will admit I do not have any children to my knowledge. But those of you who do have children, you've already done this. Ready? Clean up, everybody clean up. You've done it, right? Now the song's in your head. There you go. That's CBT. It's a mantra. And so actually, Mark, I actually disagree with what, because I hear a lot of people say that. So I totally believe that that's something you heard. Actually, it's not correcting, it's clarifying. That's what CBT, that's one of the biggest mistakes I see trainers of CBT say is it's correcting distortions. Nope, it's clarifying. So mom needed to clarify how to go to the potty, right? And so, but I've actually, so I'm over here, like my psychiatry supervisee said that verbatim statement, Mark, because his teacher said it to him. So that's one of the things we in TFCBT land try to correct, because we kind of disagree with that assessment of CBT, that it's correcting. Because also think of kind of the this is just my soapbox, think like the coercive nature. Hey, Mark, your thoughts are inaccurate, you need them corrected. Damn, like F you, Dr. G, right? And so like, well, can we help clarify? So I would actually change it to, instead of cognitive processing, I change it to cognitive comprehension. Like so Mark, let me understand kind of where you're coming from, man. That's usually my first step in CBT. But I like the clarification versus the correcting, because like, and sometimes maybe clarification helps you correct, but really we're trying to clarify. So she's trying to clarify the potty, right? Got to pee in the potty. So my 5-year-old I'm doing CBT with, I'll show you like an example I used for that kid. since they're not super verbal, like they don't write a lot, this is how I'm showing their anxiety. Like, hey, when your brother misses the bus, he thinks, let me call mom. And then your brother this is not her brother, by the way. This is like a stock image. But when you miss the bus, you act like your cat Morris, and a giant alarm in your brain goes off. And then that's why you cry a lot. And it's hard for you to do anything. So we're just going to work on making sure the alarm goes off only when it needs to. And one of the ways we do that with our very young kids is we have like our relaxation, right? And so, yeah, thank you, Tannis. I do think it's more collaborative because I was told that as a CBT clinician that you corrected. I that never felt right. And so my little kid, we use breathing. We use color breathing. Breathe in your favorite color, pink. Out your icky color, gray. We use squishies. We have a squishy s'more, so we squeeze a squishy, and then the squishy comes back. Okay. And so, by the way, I have a theory that nothing too horrible can happen to you if you're holding a squishy s'more. Okay, because the universe does not allow such ridiculousness. Correct. So I've never said, "Yo, man, my dad got diagnosed with cancer. I was holding a squishy s'more." That's a ridiculous statement, right? Now something bad can happen to me, but not that bad. Like, yeah, man, my dad got in a car wreck, drive squishy s'more, right? And so it also makes me want s'mores too, Andrea. So that's why I don't have one. I don't have two. I have 3 squishy s'mores. What? Right? Y'all didn't see that one coming, right? Nicole didn't see that coming, did she? She thought it would be another size, right? But no. This is it right here. This is it. Amazon. That's where you get them. You get them Amazon. They also got a giant waffle. Super cool, dude. I'm getting that tomorrow. Okay, that's what I'm getting. Like my squishy s'mores, dude. That's what I got. And so we do those. There's a lot of kid-friendly techniques. Like we have for like those of you who know mindfulness approaches. I'm going to give you a very ancient mindfulness technique for this age range. Ready? I spy with my little eye something green. Is it that? No. Is it that? It's the turtle. The turtle, we also use this one. Also, run DMC, Little People Fisher Price. Awesome. Amazon too. And they have the Golden Girls, folks. Okay. So turtle steps, CBT turtle steps, ready? You stop and say how you're feeling. I'm mad at a big. You go in your shell. You do a relaxer like a color breath. Or a squishy squeeze. Then you think of something green to do, something helpful. And then you come out of your shell and you do it. There you go. And those are the turtle steps. Okay. And so if you go to oklahomatfcbt.org, I'll put that in the chapter. You'll see a lot. This is for all the age range, not just the one we're talking about. You'll see a lot of these there. Okay. And so again, we have tons of these examples. I wanted to finish off this conversation with something that usually is not talked a lot about. But I did want to kind of shout out to Dr. Joy Sofsky, who's one of our researchers with this age range. I love this quote she has: kids show stress, but they also show resilience. And so the next thing I want to talk about is something called secondary trauma and burnout. Most of you have heard this term, okay? The one thing I want to add, please, and you do not have to answer this, so please don't answer this in the chat box, but I'd like you to write this down somewhere. If your job is so stressful, harmful, dangerous, all of the above, why do you keep coming back to it? Why would you do that? And I'm going to give you the answer from the perspective of somebody who doesn't do this work that you do with children. Ready? You're a crazy person. That's why. That's why Rachel's mom and dad are sending her MBA applications. Like, oh my God, Rachel, you are so brilliant. You would be a great. And Rachel's like, Mom, I got a job. Why are you sending me law school applications, dude? Like, that's why, well, because Rachel's family and friends thinks Rachel's a crazy person, and that's why they're doing that. That's the answer. Okay. And we call that, in a model we call CSR, we call it a conscious narrative. So we talked about post-traumatic stress. We talked about developmental trauma. Secondary trauma is essentially you work with people who have trauma and you have a trauma reaction. And that's what it looks like. It looks like nightmares. It looks like, sleep problems. Now, when I started learning this, I was a licensed psychologist, which blows me away because it's like being an infectious disease board certified physician and learning how to put your PPE on after you got your degree. It's weird. And when I would come to these talks, it would be like a 2-hour talk. And here's what the 2-hour talk would be. Ready? An hour 45 on definition of what secondary trauma is, vicarious trauma, burnout. and then 15 minutes of what I call lowercase s self-care, like take a bubble bath or do yoga. Now, in the CSRT model, the one I'm talking about, we are very pro bubble bath and pro yoga, and we are definitely pro tacos. It is National Taco Day. We just don't think that's going to probably cover what you're going through. So we're going to flip that for the remainder of time. The only definition you're going to learn, we're going to do that in 3 minutes. Ready? I'm going to use these terms interchangeably. Ready? Secondary trauma, vicarious trauma, and compassion fatigue. You ever heard any of those? I'm going to use them interchangeably. There are differences, but they're literally academic. One of my students is doing her dissertation on this topic. She has to know them because she's doing a DIS defense. You don't. Burnout is related but different. And here's the only definition you need. Ready? Vicarious trauma, also called secondary trauma, is a virus. Burnout is an immune deficiency or compromise. Say it again. Vicarious trauma is virus. Burnout is the immune compromise or immune deficiency. Okay? Which kind of explains a lot of the phenomena we run into. So I could say like, hey, Ingrid, you've been working in this job for a long time. Are you okay? Yeah. And Ingrid probably is fine, right? Maybe Ingrid has a great psychological immune system. I don't, but maybe Ingrid does. I have a normal one on a good day. But even if you have a great psychological immune system, there's going to be a virus that can overwhelm it. That's what COVID was about, right? Is about, not was. And that's essentially what's happening, is that no matter how good your immune system is, you can get overwhelmed. And so so here's our starting point. Ready? You can have the virus, secondary trauma. You can have immune compromise, burnout. You can have them both simultaneously. Our starting point is you're gonna get it, period. Just what you do with it. And by the way, you know, we're the only field that gives people crap for that, right? It's weird. I have an uncle who's a plumber. He comes home smelling like literal feces. My family's reaction is, that's a man right there. Theo, he's a man. He did man's work today, mijito. Like, Theo, you reek, dude. You reek so bad, dude. Like, please take a shower. Oh my God, you're so like, yeah. But you never hear this. You know, Deidre, she was crying over that family. Yeah, Deidre, that's, you know, real child care right there. Deidre's a real child person right there. You see how hardcore Deidre is crying over that little 5-year-old. No one says that, right? And so like, I guess Deidre can't hack it, huh? This teacher may need some like PTO. Like, dude, go F you, man. Like, that was a hard case. Like, that broke my heart, right? Yeah, we don't do that. It's really weird, isn't it, that we don't do that? Whereas like, if you're a plumber, you come home smelling like feces. Like, apparently you the man in my house. In the Gomez household, you the man. Dude, I gotta step out. That is nasty, dude. That's some nasty stuff. Now, here's the only other definition I'm gonna go over. This is what it looks like. It looks like PTSD. We've been talking about this the whole time. This is what it looks like. Nightmares, right? Never the kid you think, right? You think it's gonna be that 2-year-old? It's that 5-year-old, right? Like numbing out. Hey, Andrea, are you there? Yeah, I'm here. You know, we lost you for a second, Bradford. You all right? I'm 5x5, Gomez. I'm square. Right? Shutting all over yourself, right? I should have done this, and I should have done that, and I should have done here, and I should have done that. Marina shoulds all over herself every day, doesn't she? And if you ever rip your spouse a new one for no reason, congrats, you were hyper aroused. Hey, sweetie, do you want Chinese for dinner? Why does it always have to be Chinese? Okay, Italian. I'm sorry, we'll never have Chinese. I'm so sorry, right? Congrats, you're hyper aroused. Good job. These next ones are very specific to secondary trauma and burnout. General disillusionment. Like, you know, folks, I've been doing this job for like 20 years, and, you know, kids die every year. Folks, the system's more broken than ever. COVID didn't help a freaking thing. We're worse than a mental health epidemic with, hey, Gomez, that's a little heavy, man. You might want to talk to someone about that. I can't talk to anybody, Brenda. Like, okay, backing off. Now that gazelle cut from the herd, that's you. This last one, persistent constant exhaustion, the psychiatric nurse, the first inpatient unit I worked at, said it better than I've ever heard in my career. Ready? She said, I get my 8 hours every night, but I wake up and my soul is tired, and I don't know what I'm going to do with that. So how do we cope with this, folks? I'll show you how I cope. Has to be 180 proof, folks. Is it bad that I call all alcohol Pingo bye-bye juice? That bad? That's not bad, right? Okay. So Jack Daniels is the official sponsor of alcoholism in the Gomez family. Okay. We have sent more to Jack Daniels children to college than any single American family in the United States. Okay. We should get like breakaway sweatpants or something because we send so many kids. Like, yeah. So the guys who raised me are my mother's brother. brothers, my uncles, my tios, they were 3 Vietnam Marine veterans. So that was it. So they did not have a bottle of Jack, not a bottle. And so that was how I grew up. Like, I'm a Mexican dude from West Texas. We don't know where we have emotions till we're 18 and our girlfriend tells us that's what that thing is. Like, so I see that like dog and cat commercial with that Sarah McLachlan song. It's not an analogy because I'm allergic to cats. No, corazón, that's triste, that's sadness, corazón. I cried since I was 8, but not to be straight punk, right? And I know it's stupid, right? Like I have 4 wonderful nephews. Actually, 2 of them are Marines. I have 4 nephews, and I know toxic masculinity. Growing up in West Texas, I would tell these boys from the time they were young to the time they were men, okay, look, mijito, Mexicanos, Mexican men, we cry. Mexicanos cry. Crying is a show of strength. It's not a show of weakness. Mexican men, strong Mexican men, we cry. How many times have I cried in front of my nephews, folks? Any guesses? No, I ain't no punk, Vanessa. I never cry. Last time I cried was 9. You tend to be straight punk, right? I know it's dumb. I know it's stupid, and I can't get rid of it. And it's dumb. Okay, like Rosalia 2 would be amazing. Thank you for giving me credit for that, Rosalia. But yeah, I can't. And so it's bad. And so why that is relevant, is because we're going to go through, the last thing we're going to go through is what I call the approaches to secondary trauma. On one end of the continuum is what I call Can't Take the Heat. On the other, something called CSER. There is a manual for this. It's on Amazon. I'm going to show it to you right this second. And it's Dr. Brian Miller. The other one is what we call trauma stewardship. And if you don't have any background in this, if everything I'm saying is very new, then get Trauma Stewardship. It's a great book. Laura Vandernoot Lipsky is the author of it. And it looks a little bit like this. This is what it looks like, Trauma Stewardship. And it's a great book. Just read the cartoons. You'll be fine. Okay? And so thank you, Ted. Yeah, I love Trauma Stewardship. And she also has one called The Age of Overwhelm, which is amazing. And this is Dr. Miller's book. It's the CSERT model. Okay. I'm glad someone's reading it, Jody. Thank you. I had to make people read that. I appreciate you saying that, Jody. I'm glad your master's program did that because it's the exception. Like, I think I went to a good program. I didn't learn any of this stuff until I was a licensed psychologist. And so Can't Take the Heat is what I did for the longest. Okay. And I learned it at my inpatient unit. The first inpatient unit I worked at, I learned it in AmeriCorps. So my first day in mental health, by the way, I went to Sunrise Canyon adult inpatient because all inpatient units are named after salad dressings. Sunrise Canyon, Pleasant Acres, Sunny Valley. Like, we could roast a rotisserie in that, right? Yeah. And so day 1 in mental health, hour 1, they pushed me on the floor. I'm like, dude, is this safe, man? Like, 80% sure it's safe. Why are you guys behind glass? I'm 80% sure it's safe. It's like, and anyone who's done inpatient work, whether adult, children, residential treatment, anything like that, you know it's a lot like being a cop. It's 80% pure boredom and tedium and 20% pure adrenaline. You just don't know what you're going to get at any moment, right? So I work swing shift, 3 to lights out in an hour after. We just sit around the day room talking. By the way, folks, they thought I was a patient. I was like, no, I work here to like, he thinks he works and they think I'm crazy, right? That was like, I was like, okay. But I guess that helped me. But I remember the second month I was working there, I had guy my age at the time, early 20s, for 10 to 11, an hour before lights out, 60 straight minutes. He tells me the graphic details of his physical assault history by his dad as a kid. I'm glazed over. I'm clocking out. Dissociation is our correct term, right, folks? And not my boss, but this guy had rank on unit. And he looks at me, he's like, yo, man, what's up with you, man? What's wrong? And I look at him, I was like, yo, man, like, dude, this dude got the beat out of him, man. What do I do with that, man? How do I deal with that, man? And I'll never get the wisdom that man gave me that night. Paradigmatic, can't take the heat recommendation. He says, you think you got it tough, man? Did you get beat for 10 years? Walk it off, be professional. Which really didn't sound weird to me. Because again, 3 Marines raised me. And I could never complain to my tios. Like, yo, tio, I had a hard day today, tio. Well, yeah, mijito. It's in Vietnam, Da Nang, 69. Were you there? Like, I wasn't born in 68, tio. Marines don't make excuses, mijito. Never mind. So I was like, rock, paper, scissors, Vietnam. That was always how it came down to. Like, man, I like broke my leg. Yeah, I was in Nam for 3 tours. Like, all right, fine, whatever. Like, that was it. Okay. And so I couldn't complain. So it didn't seem weird. Now, that was a very overt way in which it comes out. There's a very much more common implicit way. When I work with agencies, I look for this. So in the chat box, if you've been doing this job with children or with trauma 5 or less years, if you would be okay just saying yes or no, just saying yes on the chat box, just so I can make a point. Would anyone make, okay, thanks. Okay, Moni. Okay. Oh man, a lot of people. Okay, I'm gonna go, just who's next? I'm gonna go with Maria. Okay, oh wait, no, not Maria. Let's see. Deanna. Go with Deanna. That's what I see on my screen. All right, so ready? So Deanna, I've been doing this job in child trauma for about 20 years, which means I'm kind of better than you, Deanna. I mean, see all those books, Deanna? Read those like a doctor, like National Network, she like Brown. You guys see that? I don't know if I said that already. Like I'm kind of hot, right? That's the implication, right? For Deanna. Is that since I've been doing it longer, I'm just tougher than Deanna. Here's what our secondary trauma and burnout literature show. Ready? Between me and Deanna, the person who's going to be way better at dealing with their secondary trauma and burnout is Deanna for 2 reasons. Ready? Hey, Deanna, you don't know anything. I know. Yeah. Yeah. So Deanna's going to be more open to new ideas. There is no more closed-minded human being than a 10+ year PhD. Oh my God, they're so closed-minded. By the way, not my finest moment as a psychologist, but this Texas, my defense was in Texas. Other freaking psychologists in Texas, just what I said, hey man, when did you get your degree? He's like, what do you mean? When did you get it? He's like, well, I got it. He said like 2010. Okay, what month? May. Oh yeah, cool. I just wanted to know the exact date you stopped trying to learn anything new. Sorry, not my best. Again, not my best moment. I admit that, but that's essentially it. Like there's old dogs have trouble learning new tricks, right? Again, not my finest moment. So that's reason 1. Here's reason 2. I did the can't take the heat method for over a decade. Deanna's only been doing this 5-ish years. So Deanna doesn't have to unlearn 12 years of calcified bad habits. Most Deanna has is like a couple of years. I still have to unlearn them. We had a kid 2 weeks ago, didn't even try to commit suicide, but had had a lot of ideation. One of our teenagers, I work with a lot of high-risk kids. Guess what I did for 30 minutes until we call this an accountability partner in CSER? Guess what I did for 30 minutes before my accountability partner called me up? I was like, in my head, this is what I did. How the did you miss that, Gomez? How stupid were you? You're a professional, you're a PhD, you're a national trainer, you've done this job for 20 years. How did you miss that? How the hell? Yeah, half an hour. I beat the hell out of myself. So my accountability partner texted me, he's like, what you doing? Nothing. Like kicking your own, aren't you? I'm like, yeah. It's like, you got to cut that out, man. Yeah, we're not going to let you do that. We're not going to let you beat the hell out of yourself. I still do that. And that's what I learned. Also, I grew up Roman Catholic, which means I feel guilt for stuff I could not possibly be responsible for. So that probably doesn't help. Like, he died for your sins. I know, I'm so sorry. Like, I wasn't there. Like, yeah. So that's why, I just still have the Catholic guilt. So yeah, right. Thank you, Ted. Yeah. I was like, I don't know. I couldn't possibly be responsible. Somehow I'm responsible. And so it doesn't help. But I did that. Deanna, not going to do that as bad. Maybe you'll do it, but won't do it as bad. So our younger people in the profession are actually more insulated from this. They're going to be helped. We can still do it. We just got to do a lot more moves. So it actually goes against a lot of old wisdom, which is, if you've been doing this job longer, you're somehow tougher. No, you may be number. You may be that 3rd degree burn. And it's one of the most tragic things I see when I see a provider who actually has a lot of wisdom, but is so burned out, they can't mobilize any of it. I remember this doc I worked with. I think they were actually very intelligent, but here was their reply in an ICU. I was like, hey man, our kid coded. It's like, yeah, kids die. That's what happens here. Really? That's your reply, huh? Like, you're not going to talk to the staff, you're not going to process the like, just like, that's it, kids die. Like, dang, man. Like, and so that was it, but they were having hard burnout. Now, I will say, I have had the virus, I've had the immune compromised, and I've had them both simultaneously, and I will again. And the thing I'm going to try to do different next time is just acknowledge it, right? Again, I'm going to come home smelling like feces. But hopefully that, that means, I probably care, right? One of our developers for TSCBT, Esther Demlinger over in Jersey, says, if nothing else, don't our abused children deserve one safe adult to weep over what happened to them? It's a really good point that Dr. Demlinger's making, right? Usually has good points. And so whenever I have that intense reaction, like, yeah, because this work is hard. We want to keep people healthy. And so Now, the next thing I usually find is what we call self-care. And there's a different, I call it lowercase s self-care and capital S self-care. And if you want an example of what capital S self-care looks like, I'm going to put it in the chat box right this second. And I'll show it on the share screen. We created this during the pandemic at the National Traumatic Stress Network. And this is called PRN. You do not have to do all three. Okay. So if, like Marina just does the pause, that's great. If, Chris just does the nourish, awesome job, Chris. If Diana just does the reset, way to go, Diana, you're rocking it. You don't have to do all three. Just anything to like take a break and what your brain is doing. And then there's some resources which you may already be aware of, like, the COVID Coach, which is, we created during the pandemic, Headspace, Calm Mind, anything like that. So I put that in the chat box, but I'll give you an example of like what that capital S looks like. Ready? There was a group of physicians they did a study on, and these are surgeons. And so they don't have a lot of time to do like techniques. So they gave them something called 2-2-2. So here's how it worked. Scrub up, wash up, love up. Before they go into operating room, right before they go, they do 2-2-2. Ready? So feet, 1, 2, hands, 1, 2. And they go in and operate. 3 weeks later, burnout rates cut in half. That's all they did different. So that would be capital S. Lowercase s is like, so Vanessa, I think you just need to go for a walk, get some coffee, Ingrid, Sean, just like, take some time for yourself. Like, are you doing your self-care? Tanix, are you doing your self-care? You got to do your self-care, Maria, Mark, you got to do your self-care. That's lowercase s. Now, if you're doing self-care, lowercase s, you are in a way better position than if you're doing Can't Take the Heat. There are two problems we have with self-care, lowercase s. Here's the problems. There's an empirical and a conceptual one. When Dr. Brian Miller, the developer of the CSERT model, the one I'm trained in, was looking and developing the model, he could only find one study on self-care, and it was done on medical students. And not a super sophisticated study, but it was peer-reviewed. Here's what it looked like. Control group, self-care group, seriously, group 3, this is literally what they told these guys. Ready? Do something. That was it. Hey, Sean, do something. Yeah, that was it. Here are the results. Group 1, no change. Group 3 actually improved, but it wasn't statistically significant, like P of 0.14. Self-care group got worse. Here's why. Jody, did you do your self-care? I didn't do my self-care, just like I did my case, and I did it in home visit, and I'm failing every. Yeah, I just gave Jody another checkbox on an already stressed out provider, didn't I? I didn't organically integrate the self-care into Jody. It made it her problem, not the hospital's problem, not the agency's problem, not her supervisor's problem. Like, I didn't do that. It'd be kind of like asking Jody, hey, like if she was a physician in a hot COVID unit, make sure you bring your respirator. Like, make sure you bring like your N95. Like, okay, do I need to buy that? Like we need to do that, right? And so, yeah. And like, Jody, like, I did it, right? Yeah, like I totally did it, dude. And so we agree. You did great, Jody. You did great. Now, that's an empirical problem. Here's a conceptual problem. Let's say that I'm Jess's supervisee, and Jess is a therapist working at a community mental health center in California. And I knock on Jess's door and say, hey, Jess, can I check in with you? It's like, yeah, Gomez, what's up? You remember just that 5-year-old kid we saw the other month? Yeah, the sexual trafficking kid. That was a really rough day, Michael. Are you okay? I'm on this level with you, Jess. I'm not doing too well. I'm not sleeping. I'm having nightmares. That little girl's face just pops in my head when I wanted to. I am angry all day. But my mom said, I don't know why. I'm kind of freaking out here, Jess, and I don't know what to do. And Jess says what I said as a clinical supervisor for many, many years. She says, look, Michael, that's a very common thing we deal with here at the agency. And it says nothing about you, and it says everything about the intensity of what we go through and what we see here. So look, tell you what, it's Tuesday evening. Look, take tomorrow off. I mean, I'll cover for you. No one's going to notice anyway. Just go for a run, watch a movie, play with your dog, hang out with a friend, just recharge your battery, and I'm sure you'll be fine with Thursday. And compared to Suck It Up, Buttercup, it sounds enlightened, and it is. Here's a conceptual problem. Let's say you are a licensed clinical social worker at the University of California in San Diego, and a 20-year-old sophomore named Janie walks into your clinic and says, Miss Johnson, ever since I was raped by my ex-boyfriend a few months ago, I'm not doing well. I'm not sleeping. I'm having nightmares. His face pops in my head when I don't want to. I am like angry all the time. I bit my roommate's head off. Just bit her head off. I don't know what's going on here. I'm kind of freaking out. Miss Johnson, I don't know what to do. And Jody, as a licensed clinical social worker in the state of California, says the following. Janie, that is a very common thing that happens post-sexual assault. It says nothing about you and says everything about the horrific awfulness of rape. But tell you what, well, no one will notice. I'll write you a letter. It's Wednesday. Take the day off, hang out with your friend, go for a run, watch a movie, just recharge a battery, and I'm sure you'll be fine by Thursday. So in the chat, does that sound good? Sound like okay to say to that sophomore over at UC San Diego? Good? Are we good with that? Everybody good? Anyway, I'm getting a lot of no's, getting a lot of hard no's. Okay. The CSER training is actually a full day training. So I'll do the short version. Here's a short version. PTSD criterion B, C, D, E, and F, the ones we just went over earlier. Janie and Michael are identical people, right? If we put both of them under a functional magnetic resonance imaging machine and scan their brains, they light up identically. So why do we treat them so radically different? Why is one self-care is enlightened and the other it's brutal? I think it's a licensure violation in California, to be honest, right? Why is that? Now, the technical answer is criterion A, like it didn't happen to Michael, but it happened to Janie, right? Michael didn't experience the trauma. Janie. Here's the more blunt answer. Ready? Dude, it's your job. You went to school for this. You get paid for this. You got a license to do this. No one's going to like put a gun to your head to walk in with that family. I mean, if we're going to be honest, Ingrid, I mean, you kind of put yourself in that situation. What were you wearing, Alexandra, when you worked with film? What were you wearing? Right, it's victim blaming. Now, super subtle, almost never intentional, but it devolves into victim blaming, right? And it's victim blaming in a radically more insidious way than you might even imagine. So let's say I tell Kimberly, do some self-care, and Kimberly does it, and it doesn't work. Okay. Now, obviously, you can tell at this point in the talk, I'm very sarcastic, but this next part is not sarcasm. Okay. Kimberly's best case scenario when self-care doesn't work for her is this. Michael's an idiot. He doesn't know his job. That really is. But here's what Kimberly and most of you are more likely to do. Ready? Michael seems like a smart guy. I mean, he's literally an expert in this, and he's done this for a while. I mean, it seems nice. He wouldn't give me anything to hurt myself. So I guess the problem must be me. I'm the damaged thing, aren't I? I'm not cut out for this. Maybe I shouldn't have started working with kids. Maybe I don't know enough about me. I'm just like, I never should have done this, guys. I'm so bad. Right? Sound familiar? That's what happens with depression, anxiety, PTSD. It goes inward, right? And can't take the heat, throws gasoline on that, right? It just feeds all that, right? And so we actually see self-care as high risk with low reward. And so we tend to see that like, hey, if you're doing it, it's working, that's awesome. But if you're not, please don't start it. If you like yoga, do yoga. If you don't like it, don't do it. We see that lowercase s self-care is neither necessary nor sufficient to address anything you're going through. We really don't think it's controversial to say the taco truck is not going to help when you see an abused 5-year-old. By the way, please send me the taco truck. I like the taco truck. Do not take the taco truck away. It's just not going to be the solution. Okay? But the taco truck should still come. And so that's it. So now trauma stewardship I talked about. If this is very new for you, get that book, get Age of Overwhelm. They're awesome books, very quick reads. Lovely. We love those books. And they're very consistent with CSER. Now the CSER manual, the one I talked about, is on Amazon, and it's a very in the pocket resource. The only thing I want to talk about with CSER, and this will be, I'll finish at this point and then I'll shut up, is it's really essentially two things. It's a clunky acronym, and I'm just going to break it down real quick. Components for enhancing career engagement and reducing trauma. And it's basically two pillars of research. The reducing trauma pillar that Dr. Miller had an insight on was, we don't have a lot of information on secondary trauma, but it looks a lot and acts a lot like PTSD. So why don't we just extrapolate data? So what you would tell Janie at UC San Diego is this. So Jody would say this. Janie, it sounds like you're dealing with something called PTSD. You're saying you're not sleeping. So by the way, what I'm about to tell you is a real thing. I want you to download an app on your phone called the Ptsd Coach. It was made by the National Center for PTSD. You'll get a lot of veteran examples, but you don't have to be a veteran to use it. When you're not sleeping, boot up the app. And when I see you next week on the 10th, I just want you to give me 2 tools that you could use really quickly, like deep breathing, like squishy squeezers, right? Anything like that. So we want you to have skills, but we also want you to be engaged, because in CSERT, we have a radical idea. And I just want you to go with me on this. I know it's very radical, so I apologize. You might want to like your job. I know, okay, I know I probably just split the crowd down the middle. I apologize for saying something so controversial, but we think you might want to, me and Caltrin think you might want to like your job. Okay. Now, in CSERT, you'll never hear us tell you to relax or to calm down. We won't say you need to calm down, Ingrid, you need to calm down, Moni. We'll never Taylor Swift you in the CSERT model, because have you ever had someone tell you to calm down or relax when you were pissed off? Yeah, that person deserves to be throat punched. And if I'm with you, I'll vouch for you. Like, now me and Ingrid were just talking. I don't know why that guy's choking. That's weird, man. Bizarre, right? Me and Penny were just talking. Yeah. Okay. And so, because it's not high stress that gets you, it's high stress combined with something else. It has to be high stress with helplessness, high stress with hopelessness, high stress with despair. That's what gets you. High stress is the gasoline. The spark is another thing, and it doesn't take a lot. Okay. And so so if I checked in on Deidre, I'd say, Deidre, stress 1 to 10, where you at? Personal control of Deidre over Deidre, where you at? And if Deidre said, I'm at a 9 and a 9, there to go. But if Mark says, I'm at a 5 and a 2, I need to check in with Mark, not Deidre, technically. And the way I check in with Mark is say, hey, Mark, the answer may be nothing. And you can tell me that, man. But is there anything I can do or anything we can do to help you feel more control of yourself in this moment in time? And Mark may be like, no, I just need a minute. All right, I'll give you a minute, man. And that's it. Okay. So maybe something I don't do, like maybe I just need to leave Mark alone for a second and Mark can reset. The other reason we focus on engagement is you've had plenty of these days in your job. Ready? I suck at this job. I'm awful at this job. They know I'm bad at this job. Everybody knows now. You've had tons of those days, right? But you've had the polar opposite days, few and far between they may seem, which is, oh, all right, big man, did you see me rock that? Did you see me do that? Did you see me rock that bad boy? Right. You've had those days, and those 2 days are mutually exclusive. You cannot have them simultaneously in space time. So if we give you more good provider days, your bad provider days go down mathematically. And also push a little bit. Ready? Think back to that last good provider day you had. It may be a minute. Think back. You got it? Wasn't low stress day, was it? Moderate to high, but your personal control was like an 11 out of 10. You nailed it, right? You did it. Remember that day? Like you were in the zone that day. Like you were super stressed, but you were in the zone. Yeah. So we need to give you more of those days. That's what we're trying to do. By the way, this is that other pillar comes from something called positive psychology. They use that with the NBA, the NFL, the Department of Defense for like officer training program, because we use it a lot with people who have to do high performance with like high stress. So if anyone's like a basketball fan, if you're watching, like I'm just using the Warriors as an example. If you watch, like they pull Steph Curry off the line for the Warriors and you don't know why, there's a reason. Because one of my friends, like football, one of my colleagues worked with the Warriors or worked, with the Chargers to work with their team to say, hey, when you see these things, you need to pull them off the field, psychologically reset them so that the personal control goes back up and then put it back on the game. Yeah, it's used for like high level athletics. Is where we got it from. And so that, again, the CSERT training is like a whole other thing, but I just wanted to introduce it because a lot of times when we talk about trauma, we don't talk about your secondary trauma. And I think that's something that I'm not trying to knock my program. I think they failed me in that because I'm a trauma guy. I didn't learn that till I was licensed, which is weird. The very last thing I want to go over is I want to go over 2 last things very quickly. I want to go over my philosophy of therapy and the most powerful therapy tool I could give you. Okay. Here's the quickest way I know how to do my philosophy of therapy. Ready? I'm first generation graduate. Me and my brother are the first to go to college in our family. In my family, if you don't go to prison, you hit the mountaintop. So I overshot a tiny bit. Okay. So back when I was in Texas, one of the school counselors said, we need a first generation Hispanic doctor to talk to the 5th graders. And I'm like, I'm not that kind of doctor. Like, she's freaking 5th graders. Who cares? Like, okay, I guess I'll come. And so, by the way, one to 5th grade class, it was 2 5th grade classrooms in a gym. And I followed a firefighter. Like, dude, what the heck? Man, he had like an axe in the truck. Like, look at my squishy. You see my squishy? Like, that was all I had. But they were very lovely kids. And so I say, I'm a therapist. I say that a lot. And then little sharp cookie in the front row. I say, after I finish I say, any questions? Little sharp look. I got I question. I point to this little girl. I say, "What's your question?" It's like, "What's a therapist?" Freaking little Rachel Maddow in the front row, right? I was like, "How do you explain a therapist to a 10-year-old?" And not like, "Well, you have to go to, pick the GRE and go to graduate school and then make sure you defend your," like, you can't say that, right? So I had nothing. And it was around the time the Dumbo movie came out. So I was like, okay, who here has seen Dumbo? All the kids, I actually know, we've seen Dumbo. I say, all right, point to the little girl. Say, little girl, can you say loud enough where everybody in the gym can hear it? In Dumbo, what is the feather? What is the feather in Dumbo? And here's what she says. Well, in Dumbo, Dumbo's friend gives him a magic feather, helps him fly, but his best friend's a liar. Doesn't help him fly, just thinks it helps him fly. He didn't need the feather to fly. He'd fly the whole time without the feather. It's therapist. That's it. All I am. Didn't need me Dumbo fly the whole time without me. Right? Maybe to get off the ground the first time, but I don't think so. I think he had it. Like outside of this job, the only reason I have any like hope for humanity and I have any hope in the human condition is the kids I work with. Like I usually tell my clinicians, they survive the trauma, they'll survive the recovery, and so will you. And like they survived a year of rape, they'll survive 5 months of therapy, and you will too. And yeah, they have all that straight. Like outside of this job, I'm Matthew McConaughey, True Detective season 1. Like life is meaningless and we are mistaken evolution. Like that's me normally, but like the only reason I have faith in humanity is my kids. I'm like, you still want to talk to people? Yeah. Why? They're awful. Like I think people are good. Why? Why would you think that? That like I just like, how are you doing this, man? How are you like so still care, man? It blows me away. I love it. It's just the most inspiring thing. And so the other thing I'll say is I'll give you the most powerful therapy tool you have. Ready? When you don't know, you tried the pride skills, you tried like, okay, wood versus grease fires, you tried to talk about developmental trauma, you tried all that and nothing's working. Here's what you do with the family. Ready? Here's what you do with that person. Here's what it is. Ready? The most powerful therapy skill we got. Here it is. Like 10 seconds of silence was killing most of you, all right? Yeah, that's it. If anyone's a Brene Brown fan, I call it the bear video. There's a part where she says, when people are in that deep, dark hole, they don't need you to say something. They need a connection. And that's what they really need. Okay? And so the very, very last thing I'd like to give y'all is I'm obviously a big superhero fan. So Dr. Strange talking to Peter Parker. You know what is the greatest gift anyone can receive in his or her lifetime? The greatest gift we can receive is to have the chance just once in our lives to make a difference. Do you understand, everybody on this Caltrin talk, do you all understand how many times each and every one of you has made a difference? For 100 lifetimes. So if I could give you anything, I'll just say like one thing during the pandemic that hit me is I don't think I was the best teenager growing up. I don't think I was the best person. So, and also again, I'm Catholic, right? And so like I did a lot, some of the things I did in my career. It's like, hey, I kind of had like atonement. I don't know if that's the right word, but like I kind of got to make up for the wrong I did. And then I realized at some point that whatever debt I owed, I think I paid it. And so the one thing, if I could give any of you just one thing from this talk, I would give this: whatever obligation you think you may have, you paid it. You paid it 10 times over. So you have no more obligation. I absolve you of your obligation. No obligation, only opportunity. That's what I would like to give you. Release you of your obligation and only give you opportunity. No obligation, only opportunity. That's what I'd like to leave you with.